Welcome everyone to this social media live from the Vulval Pain Society. I'm Sharon Goulbert, Vulval Pain Society trustee, therapist and pain science educator. If you can say hi in the comments, then I'll know that you can see and hear me okay. And feel free to comment, hi Natasha, great. Okay, so we are live and you can see us. Feel free to comment if you're watching the replay too. We have had questions sent in ahead of time today. So if you're watching, you're listening, you might find the answers helpful for you too. Any comments as we go along, just pop in the box. And Kay Thomas from the Vulval Pain Society, our Ops Director, will keep an eye on them on Facebook, as will I. And I'll also keep an eye on YouTube comments too. And we'll see whether we have time for more questions. Today, we have the wonderful Dr. Karen Gibbon, Consultant Dermatologist, Specialist in Vulval Skin. Hi, Karen.
Hi, good evening, everyone. Nice to be part of it. I can't see you, but to be part of it.
And, just a word for anyone who didn't catch the previous live stream back in March with Dr. Gibbon, Practical Advice for Vulval Skin Conditions. It's still up on our Facebook page and YouTube channel, so you can watch that and re-watch it whenever you choose. That was info packed. And today, Karen, you'll be sharing an algorithm for healthy skin. Tell us briefly how you came up with this. Actually, if anyone wants to know more about Dr. Karen Gibbon, watch the previous live stream, because we're going to rush through things today, because otherwise we'll be here all day with your background. But today you're going to be sharing an algorithm for healthy skin. Tell us briefly how you came about devising this, which kind of looks like a flow chart. And then let's go on to how it can be useful or how it can be utilized. And whilst you do that, I'm going to pop it on screen.
Okay. Sharon, thanks, and thank you very much for asking me to contribute to tonight's talk. The algorithm came out after I'd been a consultant for 4 or 5 years. I realized that I was sort of saying the same message, and I was hearing lots of words that women were using, which really were describing their symptoms, their feelings. And I was watching women use their hands an awful lot, and this business about describing sensation and feelings. And I just got very interested in their body language and the words they were using. And I sort of sat down one day and put them into 2 categories and thought, how can this help me as a dermatologist sort out what I'm seeing on the skin, as opposed to what I'm hearing from a woman telling me and maybe not seeing something on the skin at that particular time. And this was all really probably before smartphones. I mean, smartphones were around, but the idea that people were taking pictures of their vulva and things wasn't really around. I mean, this is going back, I think I started this, it says copyright there, 2007. So really a long time ago. And I then realized that as I was doing a lot of teaching, every 6 months or so, my registrar was changing. And so I'd have to start again with a sort of teaching, listen, watch the woman's body language, listen to what they're saying. So this chart came out as a way of trying to help patients first and foremost. So some of it's got a little bit of shorthand, which I'll explain, but really sort of to help my registrars get their head around what they were hearing and what they were seeing and why there appeared to be a discrepancy. And also, at the end of it, make the patient experience a more meaningful consultation.
Okay. Right. And does that happen often in terms of that kind of discrepancy? So a mismatch between what someone might be telling you and what you can actually see or what might be going on?
Yeah, I think that happens an awful lot. I get a lot of women coming to see me who want a second opinion about having been given a diagnosis of, say, lichen sclerosis, and I look at their vulva and I take a history, and time and again, which is lovely for the woman, I have to wrestle away that diagnosis because it's not the right diagnosis. And I say, please leave that diagnosis on my desk. that is not what I think you have. Because you're hearing that, you're hearing those words and things like redness that comes and goes. If there's no texture change to the skin, if there's no history of the right sort of duration, and the words they're using are more on that right hand side. So if you look at the algorithm there, so if you're hearing those sort of pain type of words, and you're not seeing a rash, next box down, and if you're not seeing a rash, then you sort of carry on down that right hand side, if you like, not exclusively, but if you do see a rash, you then go to that left hand side. And in my head and my training for my registrars was saying, is the architecture, is the shape of the vulva normal? And if it is, yes, then, and you're seeing a rash, then you're going down that sort of eczema, dermatitis, fluctuating pattern. And if you're not, and the architecture is not normal, you are likely to be in that lichen sclerosis or lichen planus group. And then the box down at the bottom, that little shorthand, stands for, refer for, DX is shorthand for diagnosis, IX is shorthand for investigation, and RX is shorthand for treatment. And then importantly underneath, patient request. So if you've got a woman starting on that right-hand side, you find the architecture is not normal, or you find that it is normal, but you're not getting a response to treatment, the woman's perfectly entitled to say, right, this is where we've been. I'm still not getting sorted out. And I need that referral in there. And then that little bit at the side is the lump. And again, but this is back to a physical lump that you're seeing rather than a sensation of a lump or swelling. So if there's a physical lump there, that lump needs to be explained. It's not a feeling. Plaques mean that there's texture change to the skin and obviously an ulcer. And if there's a question of cancer and a query cancer diagnosis, then clearly it's got to go down the 2-week wait pathway. So that's sort of how it sort of tends to flow through my mind. But it starts with hearing those words from what the women say their feelings are. And I think it's that bit which is so important.
So the words, for anyone who can't quite see on your screen, and I will be putting up a link to this afterwards, so you can go and have a look at it on our website. So the pain words that are in here, and I'm sure other people can think of others, but the examples here are burn, throb, raw, stabbing, sandpaper, lump. So some kind of telltale words here. And over here on this side is itch, sore, lump, ulcer, and that takes perhaps a slightly different route, perhaps a similar one, but it's a good starting point, isn't it?
Yeah, I think it's a good starting point. And if a woman's getting stuck and her symptoms are fluctuating, it can be quite helpful to go back over that and think, okay, yes, I may have lichen sclerosis, but I'm also getting symptoms and feelings that make me feel that the nerve endings are more disproportionately upset than they might otherwise be. And particularly when you've got skin conditions such as lichen planus, where you're getting changes at that junction of the outside hair-bearing skin with the mucosal skin, and that sort of anatomical vestibule area is very sensitive. And very sort of stingy and raw, and it can bleed and it can feel really uncomfortable. And putting topical steroids on there, getting the right treatment and getting the right moisturizer on first and feeling comfortable, that flowchart can help you maybe have a better chat with your GP if that's your first point of call, and to say, look, what can we do for the nerve ending aspect of this discomfort? Because I'm using the topical creams and treatments, but I'm not getting better or better enough. Is there something that we need to add in that will help with the nerve endings? And that may be simple as lidocaine, it may be amitriptyline, it may be gabapentin, or something that's actually helping with the nerve ending aspect.
Okay. And who do you envisage using this flowchart, this algorithm? Is it just clinicians, or could patients have a look at this as well, and um, also kind of point their healthcare professional towards it? How do you envisage it being used?
I'd love them to do it. Exactly as you say, Sharon, is print off a copy and, because as we know, so many women have had so many consultations with so many different practitioners. They are worn out telling their story and having, unfortunately, some clinicians' eyes glaze over because they think, look, we've checked your bladder, you haven't got cancer. We've checked this, you haven't got cancer. Consultations that are shut down rather than allowed to expand. And sit back, put your pen down and say, tell me what it feels like, and marrying up those symptoms. And yeah, I would love it if patients took this on board and went, look, I found this on the internet. Can we talk about this together? Because, I've had a biopsy. The biopsy was non-specific. Well, has that changed? Because these are the white areas that I'm developing, and taking a picture of them, for example. So there are very good apps out there. Please use an app to take your photographs and keep it so it's not put on your camera roll. Please keep it separate off your camera roll. Then it can't be uploaded to the iCloud, and whatever the iCloud is, I don't know, but I don't put any pictures up there. It's really important. So there's some very good password protected apps that you can put on your phone, and then you can keep a folder and take the pictures.
Yeah, I'm just for people looking at this on a phone, it's sort of difficult to see. However, we will be sending you a link to have a look at this for yourself in full screen on whatever device, and print it out so that you can see a bit more clearly. Okay. And I would say, I heard you say, print it out, tell your doctor or clinician, found it on the internet. I would say, tell them you found it on the Vulval Pain Society website. Because if
Yes.
you say I found it on the internet, well,
Yes.
you can find lots of things on the internet, right?
Yeah, you're absolutely right. Yeah. I think that's a really good tip. In fact, you should really put down at the bottom of courtesy of the VPS. I mean, I know it's courtesy of me, but courtesy of the VPS. So it actually gets
We might put, because at the moment it's on our web page, we might put a PDF version that's downloadable on there as well, so it could be printed out. That's a really good point. And actually, I think one of the things that people often say is that they've seen a dermatologist, they've seen a gynecologist, they've seen multiple clinicians, and everyone seems to have a different idea as to direction or what's going on. This looks like it could help with that.
Yeah. I hope so, because I have a little sort of something I learned from David Nuns, who Sharon, you know David very well. We know David as a friend and a colleague, but David as a gynecologist, and he is the president of the VPS, isn't he? Am I ever right? Is that the right title?
Trustee. He was the founder, and he's
the founder. That's
a
right.
yeah.
Yes, David and I have a sort of similar language, so that when I'm trying to talk to a woman about this, I will say, in order to manage this, we have to treat the skin. Is there a skin condition? Are the nerve endings disproportionately upset for whatever reason? And that's often multifactorial. The muscles will, in response to whatever's happening on the outside, will in turn, whether there's a degree of atrophy, postmenopausal atrophy, or spasm, but they will be in spasm, and that may need some physiotherapy. So the skin, the nerves, the muscle, and the mind, and that's not in any hierarchy order, they are all equally important, but they all interplay with each other. If your mind is not in a good place for whatever reason, and you're dealing with chronic pain, your muscles will not feel good. Your skin will just feel, just anyhow. And you see your hands are doing this. They're just frustrated and I think I might have a urine infection and it's a Friday evening consultation and you ring up the doctor says, I need to have some antibiotics, but actually that isn't necessarily the right thing I need. The algorithm may help you to actually go back through that and think, okay, that maybe is not what I need. And reaching for antibiotics, reaching for more thrush treatment, it's a kind of way, the algorithm may just give you a way of pausing and thinking through skin, nerves, muscle, mind, to see if that can somehow get you to the right diagnosis with the right clinician and getting the right treatment.
Brilliant. Okay, so I know that we've got a whole lot of questions to get through. So I'm wondering, I'm going to leave this up on the screen.
Mhm.
And should we dive into some of the questions?
Yeah, Sharon,
Yeah,
all
and
yours.
for some of them, it's going to, you know, this flowchart, this algorithm is going to be relevant. So let's dive straight in. How best to take care of vulval skin whilst showering and bathing?
Okay, lovely. So that's a nice, easy question. You use the product that you like and that suits your skin. It might be a little bit of an experiment, but simple, bland. Bland is not the same as ineffective. Bland means non-irritating. So is simple, the fewer ingredients, the better. Bland formulations, products that are generally fragrance-free, and generally products that don't foam a great deal. If you've got sensitive genital skin, then that's the sort of product that you're looking for. So generally, a moisturizing cream that you can double up as a moisturizer, so a wash cream. Some brands would be Cetraben, Epiderm, Hydromol, Aveeno, E45. They all do a cream that you can use as a wash product to put on the skin. And my little mantra, and I often ask women to take out a voice note at this point, and I say, I'm going to describe what to do. I never use any anatomical words. So if anybody else picked up that voice note and said, what the heck is this? So I will not use specific anatomical terms, but I will say, for example, with the big pot of cream, then you take a pump of it, you put that on your skin, jump in the shower. You can use whatever products you like elsewhere on your head, shampoo, whatever you want to wash, nice smelly body wash or whatever. When you're ready to come out from the shower, wash all of that off the skin. And then with your hand, the last thing you do is wash that cream off with your hand so it's gently wiped all away. Pat yourself all dry afterwards. Then take just half a pump of the wash cream, which is now your moisturizer, and put that on the skin. So it's just got time on gently damp skin, not wet, just to sink in. One of the questions was specifically about a hairdryer on a low setting.
Yes.
In this country, getting a plug in a bathroom is impossible. So if you've got a flex extension, maybe you want to, but personally, I think life's probably a bit short for finding flex extensions and hairdryers in bathrooms. So unless you move to another room and you're fortunate enough, maybe you've got a dressing room, that would be nice. But I think if you just give it a few minutes before you put your underwear on, you've trapped just a thin layer of moisture in the skin. It should be feeling a bit more comfortable. Some people may prefer an ointment preparation at that point, but if you do, just soften it in your hands first. So it just gently goes on in there. And all of that is said without any reference to anatomical terms. Then I say last thing at night, put a bit more of the cream or the ointment you prefer on the skin, and then put your topical therapy, if it's a steroid cream or something else that you need to use at night, onto moisturized skin.
Okay, brilliant. And remember, if you're watching and listening to this and you think, oh, what was all of that again and what order, you can re-watch this and replay this.
Yeah, and that's the advantage for the woman, because she can go in and listen to it again.
Absolutely. Absolutely. Someone has asked how to get a proper diagnosis for vulvodynia. Well, again, this algorithm is going to help with that. You will also find another questionnaire that our trustee, Dr. Winston Mello, has put together on our website. That, again, is another way of preparing for a consultation. So these tools, these resources are there so that you can get the best treatment for you and the most appropriate treatment for you and get a diagnosis. Moving on to the next question. My vulva becomes irritated and I experience burning every month towards the end of and following my period. What could be the possible cause of this from a dermatological perspective?
Okay, so if I heard that right, it's towards the end of the month. I didn't say specifically about in relation to menstruation, but I wasn't sure if that was implied or not.
Well, yes, burning every month towards the end of and following my period.
Yes, right. So
Yeah.
in that sense, if you've been wearing a lot of sanitary towels, for example, and we don't know what feminine hygiene products that you've been using, if there's towels and they're irritating, if they are a fragrance towel, if you're changing them too often so the skin is getting excessively dry, or not changing them enough, so you're maybe getting sweating and friction and rubbing, you may well be getting a bit of low-grade irritant dermatitis at the end of the month. And if it's again round the entrance to the vestibule area going into the vagina, then that can be often quite sort of tender or feel raw to touch. You may even get some little paper cuts there, and that would, for me, following that algorithm through, because there isn't a discharge, it's menstruation. Is the architecture normal? Yes. Then you're likely to be in that eczema or the psoriasis group, and therefore emollients first, mild topical steroid, which you can get from your GP, and experiment. You may need that for the moisturizer morning and evening for that week of your period. It's always useful to use. But a bit of topical steroid may just need it for 3 or 4 days of the month, but it just keeps you much more comfortable.
I think the other thing that comes to mind is, what sanitary towels or tampons, what are you using? Because some of these products are perfumed.
Yes.
And I would say, yeah, absolutely keep away from those.
Absolutely.
Why on earth would we need perfume anywhere near our vulvas? No,
Absolutely.
thanks.
No, absolutely.
Okay, let's have a look. I have a question about those who have mild cases of conditions such as vulval lichen sclerosis or vulval lichen planus. I have heard that unless the condition is currently active or flaring, a biopsy may come back negative, or there isn't even necessarily an obvious location to perform the biopsy, which could then be negative. Therefore, with those with mild vulval conditions, are they doomed to forever remain having mild symptoms because there's no way to be diagnosed? If so, are they still at cancer risk or not? So
Right.
a couple of things in there.
So let's deal with the cancer risk and LS first.
Mm-hmm.
Mild LS is not a cancer risk condition. All right, and I think that sounds very dogmatic. Unstable lichen sclerosis, what we call leukokeratotic, or that thickened, obviously visible lichen sclerosis, has to have another condition alongside it that increases your risk of cancer dramatically, and that is called differentiated VIN, vulval intraepithelial neoplasia. You do not miss it because there is something visible to see. There is texture change, it hurts, it's painful to touch. It's something you don't miss. So mild LS does not lead to cancer. Okay, so that's really important. Again, the reason I get a lot of women, as I said to you earlier, coming to see me is because they've had a biopsy from a non-representative area, or they've had a biopsy and it's, as I say, they've basically not taken it in the right place, or the person who's taken the biopsy has not given the pathologist the right clinical information. So biopsies taken at junctional skin, unless you tell the pathologist it's at the entrance going into the vagina, for it, it's in the vestibule, for example, you will time and time again get back non-specific chronic inflammation. Please correlate with the clinical picture, which is basically the pathologist saying, I can't tell you yes or no, you make your mind up, clinician. And that's deeply, deeply frustrating. So I don't think the woman is doomed to those symptoms forever. And that sounds awful, doesn't it? That word doom, it seems to go on forever. No, I think you can stop it. You need to get a right clinician to look at your skin. And if there are changes there, when I go to my pathologist, I will say intermittent symptoms of X, Y, and Z. Clinically, there may be some subtle pallor, which is paleness of the skin. Is this dermatitis or is this lichenoid inflammation? And I'm really putting my pathologist on the spot to say, is this dermatitis, eczema or psoriasis, for example, where you'd expect to see changes in the top layer of the skin, the epidermis, whereas lichenoid inflammation will give you more inflammation deeper down at the dermis, where the dermis meets the epidermis. And that can be quite subtle. And at times, I will go back to my pathologist and I will say, show me the biopsy, please. Nicely. I'm not that aggressive, but I'll say, show me the biopsy. Don't be like that. Can we talk about it? And I'll say, look, clinically, I'm not sure. And sometimes you do need a couple of biopsies. It's not always once that you get it right. But does that reassure that person who asked that question, am I going to get cancer? And the answer is no, you're not. If I can say that.
That's great. That's a great answer. So there's a question here. There's quite a few elements to it, but I think the answer could be the algorithm. I was diagnosed with vulvodynia after a long period of recurring thrush, 10 years, due to prophylactic antibiotic use from urinary retention. So treated with pessaries for years, came off the antibiotics, retention gone, thrush gone, STDs ruled out, HRT pessaries have really helped with skin tearing, itchiness and lubrication, but I get burning on the vulva area when I pee and sometimes after a bowel movement. Not sure if that's related, but it's been a persistent thing. Any comment on that bit there?
I think that is really back to the algorithm, isn't it? To say, we know that trigger for vestibulodynia is often that over-diagnosed condition of thrush or feelings of thrush, and over-diagnosed with vaginal pessaries and fluconazole, and nobody actually bothering to examine and look carefully for that bit of low-grade dermatitis and the upset in the skin from all those antibiotics. But I think the algorithm would help you to say that probably that particular patient, that particular question in there would say it's more in the vulvodynia spectrum, but that's not to say that your emollients don't have a place, something that's soothing, makes the skin feel more comfortable, but maybe you need more treatments for vulvodynia, which you can get from your GP.
And this woman's not sure if it is vulvodynia, well, if it's pain, if there's pain in the vulva and other things have been ruled out, then we are, just because she's saying it's quite mild, well, everyone's different. So some people experience severe pain, for other people it is mild. So, if it's a vulval pain, and that's all vulvodynia means is pain in the vulval area. And she mentions that she's tried many creams and the only one she gets on with is Dermol 500. I only use it to wash with, as I find applying creams too much, like it's over lubricated. Is that a thing that it could be over lubricated? Yeah. Can we over lubricate?
Yes. I had a woman today actually tell me about the fact that she'd stopped using coconut oil because it was ruining her clothes. It gets everywhere, It's medicated products will have what we call tackifiers. They are designed to stay tacked to the skin, and there's a variety of them. Some of them can be irritant to us, but a lot of them are there to keep the cream in the right place. And my comment at the very beginning was just use a small amount. You know, if you press right down on a pump, you actually get enough for your hands and your forearms. You think, oh, I've got loads of cream. Just that little bit. Yeah, that's all it is. It's just a little bit. It's a smooth, thin film, and then you shouldn't. But again, experiment. If creams and lotions, which are very watery based, don't feel right, try an ointment and see. Just a thin film, as I said to you, just warm it in your hands, pat it on the skin. Don't have to rub it in madly. See if that feels more comfortable.
Okay. And there's more to this question, but I think actually the person who's asked the question, I think those elements are all answered with the algorithm. It's about getting a diagnosis and addressing concerns. So this algorithm, and then we have another questionnaire on the Vulval Pain Society site, which you can just answer the questions yourself and take it into your consultation to make the most out of that consultation, that appointment. Moving on to the next question. Many women are terrified about being in a care home and their lichen sclerosis not being treated. This is very common. Is there a way of administering a steroid by injection instead of application of ointments, which might help prevent the agony of non-treatment of delicate aged skin? Likewise, what would you advise for treating atrophy when no one is permitted to introduce Vagifem nor Ovestin?
Yeah, I know. Yeah. Yeah. Oh, it is. Your heart bleeds for those women, doesn't it? It's just yes. The injectable steroids in the form of things like Kenalog and other injection treatments do not actually work for lichen sclerosis, which I think is specific what the question's aimed about there. Oral prednisolone, injectable steroids do not seem to be effective. A lichenoid inflammation needs usually only a topical treatment, and I think it's quite permissible if the woman's got a family member, if she's got competence and can make a request known, that actually it's quite reasonable that a district nurse or some nursing person can come in and administer a cream to a patient. You know, they've got consent or they've got a family member. If the patient themselves doesn't have capacity but is sitting there scratching themselves and making themselves really sore, it is cruel and inhumane to actually leave them without treatment. So yes, as a family member, get in there and say, we must have someone come in. It's not against the law to administer Vagifem. I think people are putting false obstacles in the way. You're not going to be charged with assault for helping somebody insert a Vagifem pessary, but people will often use various excuses to say, oh no, we can't do that. We don't, you know, we're not trained. Well, if you're not trained, there has to be someone who is, and please get that person, that poor woman, with the right treatment. You know, because the people who, you know, when I do see vulval cancers in people who do not have capacity, it is that thickened, grossly untreated lichen sclerosis that I see. It's not the mild end. Again, it's back to that question earlier about cancer and things. These are untreated, awful, itchy conditions. And yes, they do present late with a cancer, but that's still, fortunately, very rare. There's lots of women in care homes, I know, but in terms of that scenario, thankfully, in all my years when I was working in the NHS, that was not a common situation. And we must remember, with lichen sclerosis, cancer is less than 5% of women. And those 5% usually are much older age range, not exclusively by any means, but often in the older age range with a very thickened, different, aggressive type of lichen sclerosis.
Okay, and that's what you're talking about before, the VIN.
Yes, that's correct.
Yeah. Okay. All right. Okay. Now you're going to have to help me with this one. Thoughts on Tacrolimus?
Yay! Well done.
Yay! When steroid is not entirely keeping LS in check or is atrophying the skin badly. I've heard completely opposite opinions from top specialists and feel lost on this one.
Absolutely, that's right. And if we were American or Canadian, I think they say tacrolimus, which is so it's. But I know it's tacrolimus, so, and I think most of us in the UK would say tacrolimus. The trade name is Protopic, which might be a lot easier to say, but tacrolimus is an immune modulatory cream ointment rather, and it's divided clinicians' opinions. So I'm not surprised as a patient you've had different views. It historically had a black box warning about using it in the presence of ultraviolet light and sunshine, and had a black box warning, which is a sort of legal warning about care and recommending that it's not used on sun exposed sites when you're going directly into the sunshine. Clearly that doesn't apply to the genital skin. So there was historically some concerns about it. The black box warnings, I think, has been taken off. There was concern about reactivation of herpes simplex virus with tacrolimus. So it had bad press for quite a while. It's actually a very useful agent for, in my view, non-genital skin conditions where you are needing to avoid topical steroids on eyelids, for example. So on really thin skin, such as on facial skin, it's a nighttime treatment. You don't put a moisturizer on, but it does sting and it burns when it goes on. And there has been a vogue for using it for children when people have been anxious about lichen sclerosis and not wanting to use Dermavate. And my experience of it, I've found it a really, really mixed response. And overall, I'm still in the kind of, I think for lichen sclerosis, regardless of the age of whether it's a child or an older patient, an older woman in there, I'm still in the topical steroids are best group for lichen sclerosis, which is, I think, where that question is coming from. Does it cause vulval cancer? No, I don't think it does cause vulval cancer. I think unstable, untreated lichen sclerosis is much more of a cancer risk than using tacrolimus, because it needs ultraviolet light, I think, to be the other co-trigger for setting off a cancer.
Okay. And we've got another one here. I have super sensitive and allergic skin, and my vulval skin reacts to virtually everything, including epiderm. Blissal vaginal estrogen has helped to calm down irritated bladder and done a lot to alleviate vaginal atrophy. But I'm wondering what I could use to actually moisturize and improve my vulval skin, which continues to be thin and sensitive. Hyaluronic acid serum has built up and reinforced the skin on my face. What might have a similar effect on my vulval skin?
Well, I don't think we as yet have hyaluronic acid specifically marketed for vulval skin. I don't think it'll be long before we do, because it's a very useful product in terms of holding water in the skin. And if you wanted to, you could give it a try. I would say, if it's licensed for facial skin and it doesn't sting and it's useful, and it's, if you can find a fragrance-free preparation and it suits you, then try it and see. But it may be, going back to the algorithm, that is it actually altered sensation, and is it actually nerve ending inflammation that's actually making it feel that way, rather than actually being a true loss of water or collagen loss or whatever. So it's back to the algorithm and thinking, okay, if I put some lidocaine on, does that actually help? It's a numbing ointment, but does that actually help alleviate that symptom or not? So it might be a useful way of trying it.
Okay, all right. For a couple more here, I know we're wrapping up a little bit earlier today because Dr. Karen Gibbon is a very, very busy person. It's so grateful to have her on. There's a question here. It seems I get small. Small looks okay. It looks like a slice inside my vulval area when you pull back the fold, and then when I put V Magic or coconut oil on it for a few days, it goes away, but it does come back. Is that just from friction of panty liner or underwear?
Right. So I read the question. I wasn't sure whether somebody's got the autocorrect on, and it's kind of done that. So,
I'm doing that all the time.
Oh, whatever word I'm missing from that. What I picked up from that was, were they describing a bit of low-grade dermatitis where you might get a little bit of swelling of the skin, where it sort of feels like it's bubbling up. So dermatitis, back in that top layer of the skin, you can get little tiny little bubbles. They're not true blisters as such. This is not an infective condition, but to me it sounded inflammatory. Something was irritating the top layer of the skin, and as it swells, you get this impression of an extra fold of skin, a bit like a wrinkle or a skin crease, and there you put a moisturizer on, whatever that is, and it sort of settles. And that's how I sort of read that question. So maybe a bit of low-grade dermatitis that the panty liner is aggravating, bit of moisturizer, it all settles down, and then of course it comes back.
Okay.
So maybe using a moisturizer on a more regular basis might actually just help that symptom.
Okay, all right. Another quick question here. Does the clob cause diabetes? Now that's short for something, isn't it?
Clobetasone propionate. That's right. Clobetasol propionate, rather. There's clobetasone and there's clobetasol, which is why I always stick to the trade name of Dermavate and Umavate. Umavate is the milder one. That's the clobetasone butyrate, 0.05%. Clobetasol propionate is Dermavate, but it's also 0.05%. It's really unhelpful. So does clobber, did they say clobberderm? Was that the...
no, they just said, does the clob.
Does the clob, yes, does the clob.
It's diabetes.
Yeah, does the clob. I know what they're referring to. Does the clob cause diabetes? If you were in the realms of using 100 grams a month on very thin skin, such as mucosal skin, you might possibly get enough systemic absorption, but I think the short answer is no, it doesn't. It really doesn't. You'd have to use, what I say, industrial amounts to actually cause diabetes. Somebody, however, may have borderline diabetes, and it may be enough to just, if they were using really large amounts or using it on other non-genital areas of the skin. So if you're using it a lot on your legs and your arms, and you're really, going through a big fat tube in a short period of time, yeah, it may just trigger things, but generally I'd say not.
Okay. All right. One last question, and then I'm going to make a comment on another question that was asked. Pain at the urethral opening, could it be from soaking in borax?
Interesting. The borax argument has been around for a while, or the borax remedies and things. The problem with borax and those sort of treatments is I never know what pH they're at. And, people have a tendency, they say, make a borax solution. If I was uncomfortable, I know my tendency would be, I'll put a bit more in because then it'll work a bit better. And if you don't get the dilution right, and the preparation you're buying, you have no idea what the pH, the acidity level of that preparation is, or how alkaline it is, it's potentially not going to be helpful. So if you're using borax and that thing, it needs to generally be dilute. But if you've still got pain at a specific area and you're using that borax over the whole of the genital skin, then it's more likely to be back to the algorithm and thinking, actually, no, I think this is nerve ending if it's localized to a urethra. So I don't think the borax would be directly responsible, but I'm not a fan of borax. It's great for cleaning other bits of the house, but I tend to leave it alone.
Okay. And then there's this final one. I know what I'm going to say to it. I wonder what you might say, Karen. My GP and my gynecologist are dismissing my vulval pain. Where should I turn? Here's what I'm going to say. Seek a second opinion, different GP. Gynecologist, if that's on the NHS, please talk perhaps to PALS, the Patient Advisory and Liaison Service, because that is not good enough. Take the printed version of the algorithm to a different GP at the same practice, perhaps. We have a pre-clinic questionnaire. Fill that out and be prepared and go in and use that time wisely with that different GP. And Kay has put up the pre-clinic questionnaire, the link to that as well, in the comments. And we'll put up the link to this as well, to the algorithm as well. What are your thoughts on that, Karen, being dismissed?
Oh, I will fess up to a former life. Before I trained in dermatology, I was a GP. And the reason I got into dermatology was because I was just way out of my depth with that. And I look back on how I must have looked after some women in the early days and just thinking, yeah, I remember my dear obstetrician who's now dead, bless him. He introduced me to the word vestibulitis when I was a GP, and then went back into before I became a GP. As a junior doctor, I was an obs and gynae doctor, and he used the word, she's got vestibulitis, and I'm thinking, I have no idea what you're talking about. So it was out there, and I don't think I knew enough about it. It's back, isn't it, to this, how do you get the GP educated enough to recognize this? I very often send GPs copies of my clinic letter with a link to the VPS, or I'll print off and send them information and say, here's some more information about it. That's helpful. David Nuns, I know, has been tearing his hair out trying to get gynecologists more than half a day of vulval training in a 6 or 7 year training program, and he's worked tirelessly to improve education. But it is about education. But yes, I think PALS is a great idea, and writing a letter down about what's been happening for you is very, very important. And using those bits of the tools that Kay suggested on the link there.
Yeah, brilliant. I hope that helps you. Kay, Karen, sorry. Any final thoughts wrapping up?
No, I thought the questions were lovely. I'm sorry that clearly a lot of women out there who are struggling, but I think the questions covered a lot of what we've talked about. I just hope that, as I sort of retire from my practice, if it's the one thing that's probably attached to my gravestone, might be a copy of the algorithm and say, it's the one thing she left that was useful in this world. I don't know. I hope that other women can get some benefit from it. I know my junior doctors still use it. I'd like to think it could be just left as something to help people get the right diagnosis and get to the right treatment.
Yeah, so important. Thank you so much, Dr. Karen Gibbon, Consultant Dermatologist.
Right.
Thank you so much. And I just want to say that Karen is now one of our colleagues on the Vulval Pain Society team, so we're really grateful for her. So for those of you watching, whether you're watching live or on the replay, check out our new responsive website, which has a number of useful resources on there, and Kay has put up a link to those. Whether you experience vulval pain or you're a healthcare professional, there are resources to suit all, and this algorithm is for everyone. You'll find Dr. Karen's algorithm on there. Remember, you can watch and re-watch all of our live streams on the Vulval Pain Society Facebook page or our YouTube channel. If you'd like to be kept in the loop about upcoming events, new resources, or studies, sometimes there are studies, you can follow us on Facebook or Twitter. And a huge thank you to those of you who already follow us or interact with us or share our posts or tweet. All of that's so important because, as always, we talk about at least 1 in 7 women in their lifetimes experience vulval pain. And we really do need that education, people to be more educated about this and talk about it more openly, perhaps. And if you wish, you can also get in touch with us. info@vulvalpainsociety.org.uk. Okay, on to our next live stream, when we'll be exploring the connection between sleep and physical health, which of course includes pain. And that will be with Dr. Shrina Unadkat, clinical psychologist and senior lecturer on the Salomons Doctorate for Clinical Psychology. Dr. Unadkat will also take your questions live on the day on the topic of sleep and pain, sleep and physical health. That's 7 p.m. Wednesday, the 18th of August. Absolutely recommended you tuning in for this one, and do bring your questions, such an important area. That's all from the Vulval Pain Society now. Thank you again, Dr. Karen Gibbon. And thank you everyone for joining us today, live or on the replay. Bye for now. See you next time.